The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, and welcome to another edition of Question Lab. I'm your host, Jeff Downing, welcoming you to another evening of slicing and dicing board-style questions. Tonight, we are going to be tackling questions from Renal. So get ready for some good Renal questions. And to accompany me on this journey, I've got Sean Nanji. Sean, would you like to introduce yourself to the crowd tonight?
Absolutely. Thank you very much, Jeff. My name is Sean. I've been with RX Coach and USMLE-Rx now for over 3 years, working with students like you and coaches individually to help you on your academic journey and help you accomplish all of your goals. Looking forward to tonight's discussion.
Tonight, what we're going to do is we're going to be walking through a set of questions, and you're going to be given a chance to get a taste of what it's like to go through an RX Coach session. You know, RX Coach, we do one-on-one tutoring, and we help students preparing for Step 1, Complex Level 1, those that are getting ready for Step 2, and it's what we do is we have a method that we teach all of our mentees. So we're going to be following those steps tonight. So as we go through this, you're going to get a sense of how we advise students to prepare for these questions and how to answer them. Okay. So what we're going to do is we're going to just jump right in here. We're going to get into question number 1. And the first thing that you're going to see is that there are no answer choices. And that's by design. So the first thing that we ask you to do is we tell you to cover up your answer choices. Why do we do that? Well, the main thing here is that you're going to be hit with so much information on exam day, and there's so much that you've prepared for and studied for that it's really we feel like it's really important for you to be very methodical in how you answer every question, right? You don't really want to be jumping around. We say, first off, let's cover up the answer choices, because you may see an answer option that you're unfamiliar with. You may see an answer option that's like, oh, geez, I forgot all about it. I don't know, what is that again? Lots of different ways in which those answer choices could throw you off your game. So we say, first, cover up those answer choices. And then second, read the lead in. So the lead in is the actual question part of every item. So in this case, the lead in is, which of the following is the most likely cause of her primary acid base disturbance? Now, if you were reading, we're going to read the stem here in a minute, but you could go through that whole stems, and some of these stems these days, in Step 1, very long. There's a lot in there. There's a lot of data and labs and all kinds of stuff, right? But if you wait until you've read that before you read the lead-in, you don't know what you're looking for. You don't really have a good compass here. So we feel like the reading that lead-in helps you center yourself and figure out, okay, this is the kind of question that I'm being asked to answer, and this is the kind of information that I'm going to be looking for as we read the vignette. Okay, so that leads us to step number 3, which is we're going to read the vignette. Okay. A 25-year-old woman comes to the emergency department appearing apprehensive because of severe abdominal pain, diarrhea, and vomiting after consuming 6 alcoholic drinks at a party. She has a history of hypertension that is well controlled with chlorthalidone. Blood pressure is 116/78. Arterial blood gas analysis reveals a pH of 7.5, HCO3 of 22, partial pressure of carbon dioxide of 30, and partial pressure of oxygen of 100. So, which of the following is the most likely cause of her primary acid-base disturbance? As you think about that, What I'd like you to do is go down to the question box and let us know how many steps you think this is going to take in order to solve this question. Is it a one-step question? Is this a two-step, a three-step? Let us know what you think as I pass it over to Sean.
Well, thank you very much, Jeff. So as you can see here, we've got our vignette, we've got our lead in, and you're trying to think about, how many steps this question is going to require. We're likely looking here at a two-step question. So we've got some important clues in the vignette and lead in here where, that keyword there, primary acid-base disturbance, okay? Primary. So as you can see here, Jeff's uncovered those answer choices for us. And when we uncover the answer choices, we like to start at answer choice E and work our way up. And the reason we do that is because we don't want you to skip any answer choices, right? We want you to make sure that you're reading all of them before you prematurely or accidentally select one without seeing all of the choices. So that'll kind of force you to make sure you looked at them all, okay? Now, normally what we'll do is we'll go ahead and highlight and show you what we think is important. Today, we're going to flip it a little bit, and we're going to ask you after the question what some of the most important clues are. That'll help you get to the answer. You'll type those in the question box for us later. But that being said, we're going to go ahead and open up that poll and give all of you a chance to lock in your answers.
Okay, so you've got all of the answer choices there in front of you. So let's go ahead and launch the poll and let us know which of the following is the most likely cause of this patient's primary acid-base disturbance. That first answer is alcohol effect on central nervous system respiratory centers. Got a character limit here in GoToWebinar. Let's see, about a little over a third of you have cast your vote, so we'll wait for everyone else to get in there. Okay. So again, we always recommend that, hey, look, on test day, you never want to leave any question left unanswered. So go in there. If you don't know it, take a shot. Looks like we've got a two-horse race really for this one. So let's go ahead and close the poll and share the results. So looks like most of you went with either answer choice E or D, so vomiting or hyperventilation due to pain. Some of you went with alcoholic ketoacidosis. So again, we got a lot of you kind of focusing on one of two answers. So I'm going to hide the results and get ready to reveal the answer. And the answer is answer choice D, hyperventilation due to pain. So we can't count that as a win tonight. It was close, but that answer choice D was our number 2 vote getter. But regardless, if you didn't get this one right, that's okay. Sean's going to be here to walk you through the answer.
Well, thank you very much, Jeff. So yes, another challenging question, but it looks like 38% of you got it right, which is pretty good, okay? Because this, like I said, is a challenging question. So what's going on here? So if you look at the profile here, we can see that we've got a high pH, a low PCO2, and a slightly low bicarb level, and that's because this patient has acute respiratory alkalosis. So why is the PCO2 low? Whenever you see PCO2 low, you want to start thinking about hyperventilation, because what happens is as you're breathing fast, you're blowing out more and more carbon dioxide, so that PCO2 is going to drop. So you've got the high pH, low PCO2, and slightly low bicarb. That's because this patient has acute respiratory alkalosis. So in respiratory alkalosis, what happens is you have a release of hydrogen ions from these non-bicarb buffers, and that leads to a fall in bicarb levels. But what happens, and we know it's acute, right? because if it was chronic, that bicarb level would be even lower, okay? And that would happen if it's chronic, because what will happen in that situation is the proximal tubule will stop reabsorbing bicarb, and you'll have some compensation as a result. So what's the mechanism here? Well, respiratory alkalosis can be caused by a couple of different things, right? We can have it caused by a hypoxia, but we don't see that here. Or we could have it be primary hyperventilation due to pain, anxiety, aspirin. And if you aren't familiar with the aspirin profile, there's certain things that happen at the beginning when you take aspirin, then kind of 15, 20 minutes later, and then even more time passes and that profile changes again. So take a look at that aspirin profile. It's not what we're talking about here, but you will likely have a question about these levels as it relates to aspirin. But what is happening here is this patient's likely in pain, okay? You could also have a hyperventilation due to a PE. But in this case, we've got patient's pain, which is likely causing her to hyperventilate, leading to that respiratory alkalosis. And once again, those levels will help you come to that conclusion. Now, as always, and when you're doing questions, we want you to do the same thing, which is, we want you to, look at the right answer and make sure you got it right for the right reason. But we also want you to review the incorrect answer choices just to make sure that you're learning from those as well, okay? You should spend time reviewing your answers, correct and incorrect, when you're going through the questions that you're doing. So let's start at the bottom and work our way up. Vomiting. Well, vomiting will cause a metabolic alkalosis that's secondary to the loss of hydrochloric acid from the stomach. But when that happens, you're not going to have low bicarb, right? You're going to have a high serum bicarb. And so we don't see that high serum bicarb here. That helps us rule out vomiting. And I know, that was our most common answer, right? So what's going to help you get that right is remember this, that when you're vomiting, you'll have metabolic alkalosis secondary to the loss of hydrochloric acid. But as a result of that, you're going to have a high serum bicarb. It will not be low. So that was likely why many of you were thinking that was correct, but maybe missed one important clue there, or it's been a while since you've seen it, which is why we're reviewing everything here today, right? We talked about D and why that's the correct answer. Diuretic use. Well, diuretic use is going to cause volume depletion. And when you have volume depletion, you're going to have metabolic alkalosis, because when you have volume depletion, you're going to have, eventually loss of renal hydrogen ions, and you'll stimulate aldosterone. And that is going to cause you to secrete hydrogen, right, to compensate. And in that case, also, the bicarb will be high and not low. So once again, that bicarb level so far should help you rule out diuretic use and vomiting. Let's go to alcoholic ketoacidosis. High alcohol ingestion, that's going to cause a respiratory depression. And then you'll have respiratory acidosis, and the PCO2 will be high, because when you have respiratory depression, you're not breathing out that CO2 as fast or as much. So that PCO2 level will be high and not low like we see it here. Answer choice A, we're talking about alcoholic effects on the central nervous system respiratory centers. Sorry, that was answer choice, that was a high alcohol ingestion we talked about already. I skipped this one here, alcoholic ketoacidosis, my apologies. That's going to happen, a day or two after excessive alcohol ingestion. And that's normally going to happen when patients are malnourished. And once again, you're going to see a low pH. It won't be increased. Okay, so to recap here, high alcoholic consumption, like we're talking about answer choice A on the CNS system, that's actually going to cause you to have respiratory depression, leading to pH being low and PCO2 being high. And alcoholic ketoacidosis, B, just for good measure, since I skipped a little bit here, will occur a day or two after you have that alcohol ingested, mainly in patients who are malnourished. And as a result of that ketoacidosis, you'll have metabolic acidosis with a low pH and not a high pH like you see here. So great job, everyone. Definitely a tough question.
Yeah, it was, and that was a good, again, good way to get us kicked off here. Let's keep the party rolling, right? Let's go into question number 2. And again, what we're going to do, we've got those answer choices covered up, and we're going to start with the lead-in. Which of the following drug mechanisms best explains why amoxicillin is prescribed at a reduced dose in this patient? Okay, you've taken a look at the lead-in here. You kind of understand what we're looking for. We're dealing with amoxicillin. And we're ready to move to the vignette. A 48-year-old man comes to the clinic because of a 4-day history of pain in the left ear. His medical history is significant for gout, for which he takes ibuprofen, allopurinol, and probenecid. Otoscopy shows an erythematous, bulging left tympanic membrane. He is prescribed amoxicillin at a reduced dose. So again, which of the following drug mechanisms best explains why amoxicillin is prescribed at a reduced dose in this patient? Again, head on down to the question box. Let us know how many steps you think this one will take to solve as I turn it over to Sean.
Well, thank you very much, Jeff. So, we've got a pretty straightforward question here, right? We need to figure out the mechanism of this drug and why it's going to be, contraindicated or had given at a reduced dose. And in order to get that right, we want to think about his medical history, right? Look, significant for gout, for which we know he takes 3 different medications. So with that being said, let's take a look at those answer choices. Keep those clues in mind. Answer choice E, inhibition of the organic anion transporter. D, induction of cytochrome P450. C, increased tubular reabsorption of antibiotics. B, decreased glomerular filtration rate or a decreased GFR. A, competitive inhibition of xanthine oxidase. So with that, we're going to go ahead and open up the polls and let you lock in your answers.
Okay, everybody, here we go. We're going to launch this poll. Let us know which drug mechanism best explains why this patient's physician prescribed amoxicillin at a reduced dose. Quite a few variables you need to be able to work through here. Hopefully you've got a good read on this one, and we're going to let the votes roll in. Once we get to about 70%, we'll close that poll and share the results. As a reminder, we're going to have a raffle at the end of tonight's session. One lucky attendee is going to get a subscription to RX 360 Plus. That includes all of our great Step 1 tools, including Step 1 QMax, Express Videos, Flash Facts, all of the RX bricks. And of course, bricks, now you have the ability to create your own bricks with the Bricks Create authoring tool. Plus, it's all turbocharged with first aid content. So anyway, someone is going to be a winner tonight, so make sure you stick around. Let's see, we've got over 3/4 of you have voted, so I'm going to close the poll. And let's share the results. So this one's a really interesting one. We've got a 3-way battle between answer choices B, C, and D. Induction of cytochrome P450 was the top vote getter, but increased tubular reabsorption of antibiotics and decreased glomerular filtration rate right on its heels. So with that, I'm going to go ahead and hide the results, and let's go ahead and reveal the answer. And the answer is answer choice E, inhibition of organic anion transporter. So here we are. This was the answer choice that received the fewest number of votes. So this was a real tough one. So Sean, you're going to have to walk us through this.
Well, thank you very much, Jeff. Happy to do that. Definitely a challenging question, right? It's one of those questions that you need to know about medications and how they work. And sometimes those minute details are easy to forget, right? And that's likely why many people miss it. So let's talk about what's going on here. So they told us that he's on several medications: ibuprofen, allopurinol, and probenecid. So what's the mechanism of action of probenecid? Well, probenecid is used for gout. And what it does is it inhibits urate absorption in the proximal tubule. However, it also will inhibit the organic anion transporters in the kidneys, reducing the excretion of several drugs like penicillin, thereby raising their serum concentration levels. Okay, so let's talk about this again. So we use probenecid for gout because what it'll do is inhibit that reabsorption of uric acid in the PCT, or the proximal convoluted tubule. And by doing that, it'll reduce serum uric acid levels. Now, because it also inhibits the secretion of penicillins by inhibiting these organic anion transporters in the proximal tubule, what happens is probenecid, as a result, will increase the serum concentration of penicillins like amoxicillin, which will then, cause you to want to do a dose reduction. Okay, so you need to know the mechanism of action of that medication in order to know why we're giving reduced levels of penicillins, and it is a high yield question. So make sure you review that, and we're going to talk about why the other answer choices are incorrect here in just a second. So once again, we know why E is the correct answer. Let's talk about answer choice D, induction of cytochrome P450. Liver metabolism. So when you inhibit cytochrome P450 liver metabolism, you can raise some drug levels, but it's not going to affect amoxicillin metabolism. And there's some mnemonics out there like wet PD and other ones of drugs that you'll have increased levels of when you inhibit CP450. But amoxicillin and penicillins aren't really one of them. So that's why that answer choice is incorrect. C, increased tubular reabsorption of antibiotics. Antibiotics like penicillin and sulfa drugs, they're secreted by the renal tubules, but they're not reabsorbed. So that's not going to be the correct answer. Decreased GFR, ibuprofen. If you're thinking that answer, you may think, okay, ibuprofen is going to decrease GFR, but it's not going to be to the point where you need to reduce the dose of amoxicillin. Okay, so it says when you're looking at these answer choices, you're supposed to pick what the best answer choice is, and the best one is E. Okay, A, competitive inhibition of xanthine oxidase. Well, xanthine oxidase inhibition, we're talking here about allopurinol, which this patient is on, but once again, that medication does not affect the metabolism of amoxicillin. So once again, one of those questions where you need to know your farm well in order to get this question right, a detail we may have forgotten, but hopefully you'll remember it after today. Jeff.
Yeah, this one is, I think it's going to stick in a lot of folks' memories. This is probably, I think, out of all of the over 150 episodes of Question Lab, this may be probably the question that would be considered the toughest, just because of the low percentage. But that's okay. Again, this is the time to get these questions incorrect, and the main thing is we want you to leave this session a little bit sharper than you were coming in. So well done to those of you who got this one right, and everyone else, just we're going to just keep on plugging away here, right? So we're ready to move to our next question, the second half of tonight's event. But I do want to remind you that our RX Coach tutoring service is currently accepting students. For those who are unfamiliar with Coach, or those who are, really kind of thinking about, hey, what do I need right now? If you're, in the process of evaluating tutoring services, you're going to see a lot of different options out there. For us, we pride ourselves on a personalized one-on-one approach that starts with a 160 question assessment. So basically it's like it's a half day self-assessment exam where you are able to kind of share and show, hey, what do you know? Right. And we take the results of that and we work with you to put together a personalized study plan. So, you may be really, great at biochem, but really struggle with renal. And, we would, make sure that your coach is thinking about that as your plan is getting mapped out. Now, some services will do like group tutoring or online class tutoring. There's lots of different things out there, but for us, we feel like that one-on-one approach where your tutor knows about you and you're able to kind of form that relationship is the most effective in time. Now, on top of all of that, you do get full access to all of our products, all of our RX 360 plus items, which includes bricks and includes Step 1 QMax. And at the end of the day, we want to align our goals with yours, and we feel like out of the hundreds of students that we've helped do really well on the boards, including getting high scores on Step 2 and passing Step 1 and doing well on CBSEs. Lots of different reasons why you may feel like you need a a passionate tutor, and we're here to help you achieve those dreams. So what you can do if you want to learn more is you can go to our site at www.rx-coach.com. I'm going to put that in the chat for you, and you can set up a free consult to learn more about the program. And if you like what you hear and you find yourself at that point where, yes, I could really benefit from someone keeping me accountable and someone who can help explain the types of questions that we just worked through, let us know. Okay, so with that, let's go get ready for the second half of tonight's session. And we're going to start once again by covering up those answer choices and reading the lead-in. Which of the following is the most likely diagnosis? Okay, so that's the lead-in. Classic Step 1 question, right? So with that in mind, knowing that we're going to be looking to come up with a diagnosis here, let's read the vignette. A 66-year-old man comes to the clinic for routine follow-up. He has a history of type 2 diabetes mellitus, hypertension, and chronic kidney disease with a baseline serum creatinine of 2.2. He takes metformin, enalapril, and diltiazem. Physical examination is normal and he feels well. Laboratory studies show the following lab numbers. You can just, I'll let you read those yourself. So once again, taking all of that in, which of the following is the most likely diagnosis? We've already figured out this is a one-step question, so I'm going to hand it over to Sean to take it from here.
Well, thank you very much, Jeff. So once again, some important clues here, right? We know the age, 66 is routine follow-up. Got type 2 DM, hypertension, chronic disease for kidneys. Look at that creatinine baseline here. Look at all the different medications that he's on. Physical exam is normal. And now you look at all these lab values, right? And, it's easier sometimes, when you're taking the step as far as lab values, because you'll see the normal lab values, you can pull them up. Right now, you can't do that, right? But, that being said, let's go ahead and uncover those answer choices to figure out what the most likely diagnosis is. E, type 4 renal tubular acidosis, or RTA. D, type 2 RTA. C, type 1 RTA. B, hyperaldosteronism. And A, acute kidney injury. So once again, we're going to open up the poll and give all of you a few moments to lock in your answer.
Okay, everyone, let's go ahead and launch the poll. Once you see it show up on your screen, select the answer choice which you think is the most likely diagnosis. Kind of a classic renal setup here, so hopefully you're all warmed up by this point of the night. Okay, almost half of you have cast your vote. I'll give you a little bit more time to make your selection. Looks like we've got a clear front runner so far. But as we've already seen, that doesn't necessarily mean anything, right? So let's everyone just make your most informed pick, and I'm going to close that poll and share the results. So about 40% of you went with type 1 renal tubular acidosis, while about a quarter of you went with type 2, and then trailing that type 4. So vast majority of you went with a one of the types of renal tubular acidosis. So very good. So let's go ahead and hide the results and see what the answer is. And the answer is type E, or sorry, E, type 4 renal tubular acidosis. So out of all the types, this was the one that received the fewest number of votes, but turned out to be accurate. So another tough one here, Sean. What's the story behind this one?
Sorry about that. I believe I was on mute. So, another challenging question here, right? So let's take a look and see why. The first thing we have to figure out is, what the disease is and what the mechanism is. So if you look at the lab values and you're able to, compare them to normal, you'll realize that this patient has normal anion gap metabolic acidosis, which means you've got low bicarb and pH with hyperkalemia. Okay, so low bicarb and pH with hyperkalemia. So based on that, and combined with the fact that this patient is on a angiotensin converting enzyme or ACE inhibitor, it's likely that we've got type 4 or hyperkalemic renal tubular acidosis, which is the most common type. Okay, so how do you calculate the anion gap? You want to take the sodium, you want to minus it from the chloride plus bicarb. Okay, so you take the sodium and you minus it from the chloride plus bicarb. And so that'll put you at 12. Okay, so that'll tell you that's a normal anion gap metabolic acidosis. And that's going to be caused, because you've got diarrhea and renal tubular acidosis, where the kidney fails to excrete acid properly. And out of all the types of RTA, only type 4 is going to show hyperkalemia, which you do have in this patient. Okay, so that's why this is the correct answer here. Once again, you need to know that lab value and realize that it's normal anion gap and that the potassium's high. And once you figure that out, right, then you'll know that only one of those RTAs is associated with that high potassium or hyperkalemia. Type 2 RTA, that's because you have impaired bicarb reabsorption in the PCT, and you will have hypokalemia, and that's usually seen in childhood. Okay, type 1 RTA, that's going to be also characterized by hypokalemia, and that happens when you have ineffective hydrogen and potassium transport in the renal collecting tubules, and that leads to metabolic acidosis with low serum potassium. Hyperaldosteronism, that's going to lead to metabolic alkalosis, not acidosis. And once again, you'll also be accompanied in that case with hypokalemia. So that potassium level should help you rule out 3 out of 4 of these incorrect answers, or just pick the right one right away. Acute kidney injury, that's going to be when you have like a sudden decline in kidney function in a short period of time, and you'll have a significant rise in creatinine, but you're not going to see, this anion gap, this normal anion gap metabolic acidosis. So once again, that pH and the potassium are really key here to give it get to this right answer. And even if a lot of people here didn't calculate or forgot how to calculate that anion gap, that potassium level should really help you rule out a lot of the answer choices and get to the right one. So definitely a challenging question, hopefully we've got some good takeaway points here to get this question right on test day. Back to you, Jeff.
Yeah, another one that's covering some of the key renal concepts. If you didn't get it right, that's okay. Our goal here is to make sure you're a little bit better prepared for these types of questions on test day. So with that, we've had a pretty good night of questions so far. These have definitely been challenging. Let's see if we can close strong with our final question of the night, which is question 4. So everyone knows the drill by now. That's a pretty short one here, so let's go ahead and read the lead in. Low total body levels of which of the following would most contribute to this limited urinary concentration? Okay, so we know we're going to be looking for something where low levels might contribute to a limited urinary flow. So let's read the vignette. A public health research study investigates the kidney function in children with severe protein-calorie malnutrition. They note that the children are not able to fully concentrate their urine in response to low fluid intake, contributing to dehydration. So low total body levels of which of the following would most contribute to this limited urinary concentration? Think about how many steps you believe this might take and let us know in the question box as I pass it over to Sean.
Well, once again, a great question here, and one of the ones you'll start to see these shorter stems and vignettes on steps. So, what are we looking at here? Well, we've got a study here with children, kidney function, severe protein-calorie malnutrition, and said that they can't fully concentrate the urine in response to low fluid intake, and that contributes to their dehydration. So, total body levels of what will contribute most to this limited urinary concentration? So, we're going to open up that poll and let's see what the choices are here. Answer choice E, urea, D, phosphate, C, glucose, B, calcium, and A, albumin. We're going to go ahead and open up the poll and give all of you a few moments to lock in your answers.
Okay, final question of the evening. Go ahead and make your selection. Do you think it's albumin, calcium, glucose, phosphate, or urea, which is, if the levels of that were of those were low, would most contribute to the limited urinary concentration within these children? Okay, looks like we've got over half of you have already made a selection. Looks like it's a 2-horse race for this one. Give you just a few more seconds and we're going to get ready to close the poll. Okay, here we go. We're going to shut her down and let's share the results. So almost half of you went with albumin and about a third of you went with urea. So that right there, over 75% of the votes here. So let's go ahead and hide the results. And let's find out what the answer is. And the answer is urea. So nice work, everyone. The second place vote getter here, but represents about a third of you. So nice work. If you didn't get it right, that's okay. Let's break this one down, Sean.
All righty. So, renal is one of those topics, especially when it comes to renal physiology. It gives students some trouble, right? So let's just talk really quickly about a little bit of basic renal physio. So in order to concentrate urine, right, you need ADH to cause the principal cells of your collecting duct to become permeable to water, right? And it also requires that the medullary interstitium of the renal, the medullary renal interstitium, be hyperosmotic so that water can be pulled in from the lumen into the interstitium. So the concentrated renal medullary interstitium is comprised of both urea and sodium chloride, which both contribute about half and half, or 50% each, to the osmolality. So if you have low circulating urea, you will have lower interstitial urea concentration, and you'll limit the concentration gradient. You'll reduce the interstitial osmolality, and therefore reduce the ability to reabsorb water. Okay, so the take-home points to see why this is the correct answer is that both urea and sodium chloride contribute to the ability of the renal medullary interstitium to concentrate urine and are essential to maximize that water reabsorption and urine concentration. Okay, so out of those two, sodium chloride and urea, you've only got one choice, and that choice there is urea, making that the correct answer. Now, once again, let's talk about why the other chances are incorrect. Phosphate, that's reabsorbed in the tubules, but it does not really contribute to urinary concentration. If so, that contribution is very minimal, so that's not going to be the correct answer. Glucose, you may see that in malnutrition, but you're not going to have that contribute to urinary concentration, and that's likely a good distractor because students will see here that malnutrition and think that glucose may contribute to it. Not the case here. I see that a lot of you didn't fall for it, so that's great. Calcium, well, that's reabsorbed in the tubules, and once again, hypocalcemia would not really limit your ability to concentrate urine. Now, a lot of you selected albumin. Okay, the one thing to know about albumin is, going back to the first thing, that urea and sodium chloride are really the drivers behind urine concentration, but albumin is only minimally filtered into the nephron. And albumin does not contribute to renal concentration, so that's why that's the wrong answer. So a lot of people selected that answer, and what you really want to know is what is going to be responsible for urinary concentration. We've talked about that a few times here tonight with this question, but for good measure, at the end here, we will put those QIDs up so you can review them on your own time. And as always, if you're having trouble understanding these concepts, right? Feel free to reach out to us at rx-coach.com. We've helped students that have passed, that graduated 15, 20 years ago. Now, if we can help them, we can certainly help you. The students always come to us and say, "Oh, my studying became so much more efficient when I got a coach with RX Coach." And every student that's come to us has accomplished their goals, and we'd love to make you one of our success stories. With that, I'll hand it back over to Jeff.
Yes, we certainly do. Thank you, Sean, and definitely thank you for leading us through tonight's edition of Question Lab. We do have all of those QIDs here up on the screen, so make sure you take a screenshot of them or write them down. Again, you can go to, if you've got an RX subscription, you can go in there and plug those QID numbers into search, and you'll be able to get all of the information, including all of those explanations and the first aid references and first aid pages in there. So make sure you check that out.